P is overlapping the preceding T, isn't it? So, what has happened? We call it premature atrial, which has come in an improper place.
But this you can learn. Even for experienced hand, this is very difficult to find it easily, I tell you. Many times I missed it. Even for my father I missed it. Very difficult. Isn't it, sir?
Yes, it is a little bit difficult to understand premature atrial contraction. And one thing is there, it can be confused with some other kinds of arrhythmias. But knowing that this kind of arrhythmia is there is also beneficial. So sometimes during two abnormal firing of somehow conduction from atrium, this P can be there, and atrium will be contracted whenever there is no need for atrial contraction. If we see frequent premature atrial contractions in the rhythm stream, that can lead to some kind of cardiac output problem. Why? Because you are pumping the atrium into the ventricle when there is not enough need. The ventricle may be full. So you are pumping blood to ventricle which is already full, and when the ventricle needs the blood the most in the time of relaxation, maybe there is no atrial contraction. So some kind of loss of harmony is there between ventricle and atrium because of actually improper atrial contraction. So PAC can be due to abnormal contraction from atrium to the ventricle.
SVT, sir? Are you trying SVT?
It's actually yes. It is atrial tachycardia. You see something in this rhythm. The rhythm is regular. More or less the rhythm is regular. The speed is high. Okay? Speed is, it can be up to 250 per minute. But the rhythm is regular. Where is the P wave? We don't have any P wave here in this rhythm, do we? It is actually buried in the previous T. We don't have that typical ECG here. The shape has actually somehow changed. P and T have become one. because of the very high rate. We said that after SA node, the conductor is leaving. Okay? Here, the atrium is conducting with atrium is very fast, and the conduction is also very fast. Conduction to the ventricle is also very fast. So each impulse, each fast impulse generated in the atrium is coming to the ventricle, leading to tachycardia. So we have a high rate. They call it supraventricular tachycardia. Can anybody tell me about the PR interval in this rhythm? Actually, there is no PR interval. You cannot measure PR. How can you? We don't have any P. So just remember, we cannot measure PR interval. P is buried in the T. Have become one. The speed is high, but the speed is regular. You see, the regularity is there, but speed is very high. So we call it
how to differentiate it from sinus tachycardia?
Sinus tachycardia. Sinus tachycardia, we have normal P, normal T. You remember, in sinus tachycardia, all the shape is normal. Okay? Only tachycardia is there.
Paroxysmal atrial tachycardia and SVT.
So paroxysmal atrial tachycardia can have the same feature, but it is paroxysmal. We will have after few bits, we will have again normal rhythm. So basically, in sinus tachycardia, just remember that the shape is like this. Very normal. Everything is normal.
Sinus tachycardia, paroxysmal atrial tachycardia, supraventricular tachycardia. These three.
This is another rhythm abnormality, and it is a dangerous one also. Can you tell me what it is? Atrial flutter. Very good. It has a very, very unique feature. You see that these are sawtooth, like sawtooth. Sawtooth.
Sawtooth. Manalakala katti.
Yes, exactly.
Endu varai Malayalatile? Arukkuvaadu. ഇതൊന്നും നമുക്ക് വരത്തില്ല ആയുർവേദത്തിൽ. നമ്മുടെ ചികിത്സ തുടങ്ങി നമുക്ക് പുള്ളിക്ക് ഒന്നിനെ പ്രസ്താവം അതിന് മോക്ഷപ്രാപ്തി കിട്ടും.
Sawtooth appearance is there. The speed is high. Atrial speed. Atrial rhythm is very fast. Ventricular rhythm is slow. So we have irregularity. Irregularity is there.
So you teach atrial fibrillation and stuff, sir? Huh?
This type of arrhythmia can be very dangerous. It can lead to decreased cardiac output and sometimes actually loss of, we can call it something like heart failure. Why? Because the contraction of the atrium is not very effective. We should do something about atrial fibrillation and change the rhythm. Sometimes they do DC cardioversion, this electrical shock. Sometimes they use some other drugs like propranolol, beta blockers, like calcium channel blockers, verapamil. These are the drugs most commonly used for this condition. Adenosine can be used. Sometimes other anti-arrhythmic agents also can be used. But these are the basic drugs that we use for this condition. This is considered among the all arrhythmias we discussed here in the atrial tachycardia, atrial category. This is the bad one. Remember, if you see sawtooth, it's a bad sign. you have to do some intervention to stop it.
SVT Ayurvedically we can manage, sir.
SVT is easy to manage. Don't panic from this one. This doesn't have a good shape. Doesn't look friendly, but actually it can be managed easily. Don't worry.
SVT na 10 patient was it. Saatu paadu. Ye mess onadu SVT. Ala.
We still haven't reached the AB node. We are just talking about atrium and the SA. Okay? There is one more condition in the atrial arrhythmias. Okay? That is called atrial fibrillation. This is flutter. Atrial flutter.
Can atrial fibrillation can be diagnosed by pulse alone? Sir?
By pulse alone, sir, it should be the only thing. It's not specific, but if we want to check by pulse, it should be very, very low pulse, very, very weak pulse.
2-3 cases I have diagnosed through pulse.
So it's not a specific sign. We can somehow say that it can be there, but not 100%.
Can be confused with ventricular extrasystoles also sometimes.
Yes, by pulse, by checking pulse, it can be like that. Yes.
ഇങ്ങനെ പഠിക്കുമ്പോൾ ഇതിൽ ആർട്ടിഫാക്റ്റുകളും atrial fibrillation എന്ന് പറയാൻ സാധ്യതയുണ്ട്. Artifacts. Sir, you tell about artifacts also, sir. Our ECG machine produces fibrillation in every case.
So take a look at this rhythm. Is it regular?
No.
Is it regular?
No.
It's very irregular. You look at this. This is one rhythm. This is one rhythm. This is one rhythm.
Very normal.
Irregularity is there,
waves.
both in ventricular beats and in atrial beats. Actually, you don't see any P wave here, do you? There is no typical P wave that we discussed before. Is there? It's some waves. I mean, fibrillatory small waves are there, but we cannot call them P. They call them fibrillatory waves. We don't have any atrial contraction as such. What happened here is that atrium wants to contract, but instead of doing this, it's doing this.
This is very, very important in Ayurvedic practice.
Small fasciculations are there. Atrium doesn't contract. It's doing like this. No contraction is there. So you see small fibrillatory changes, but no contraction. But actually in this condition, it will lead to blood staying there in the atrium. It will not pump out into the ventricle. So what will happen? The blood will stay. In stasis of blood lead to clot formation. So whenever you pump it, after some time, the clot will go into the systemic circulation. It can be dangerous, okay? But still ventricle is working properly, more or less. Ventricular action is there. Usually this is less dangerous than this one. I told you, whenever you saw sawtooth, you be careful. This can be managed by DC cardioversion, or the best thing, propranolol, amiodarone. So many drugs are there that can control this.
What about quinidine, sir?
Quinidine also. Quinidine, verapamil, amiodarone, procainamide, carvedilol, this can be used. But basically, what are we using is adenosine and propranolol and verapamil. So this is a good one, though everything is irregular. One other name of atrial fibrillation is irregularity, or irregularly irregular. So this is all about the SA node problems and atrial arrhythmias. After that, we continue with the AV node problems. conduction abnormalities in the AV. First we discuss the sinus problems, then we discuss the atrial problems. In the sinus problem, which one was the serious one?
6 sinus.
6 sinus. 6 sinus. Very good. In atrial problems, yes, atrial clutter, which we see sawtooth appearance, dangerous ones. So these are the most important ones in the sinus and atrial. After that, we actually start with the AV conduction abnormalities and ventricular conduction. Okay?
Can we have our next class here? Next seminar. അങ്ങനെയല്ല, എനിക്ക് ഒരു മാസത്തിന് മുമ്പ് അറിയാൻ എനിക്ക് ഭയങ്കര തിരക്കുള്ള ഹോബിയാണ്. അതുകൊണ്ട് ലീവ് ഞാൻ നേരത്തെ അനൗൺസ് ചെയ്തില്ലെങ്കിൽ ഭയങ്കര കഷ്ടമാണ്. അതുകൊണ്ട് നിങ്ങളുടെ പ്രോഗ്രാം 40 ഡേയ്സിന് മുമ്പ് എനിക്ക് ഫിക്സ് ചെയ്യണം. Then only I can maintain regularity for you. ഭയങ്കര തിരക്കായിരുന്നു, ഒരു രക്ഷയില്ല. ഇന്നലെ രാവിലെ അവർ വിളിച്ച് തൃപ്പണിത്തറ വരണം 11 പേര് പറഞ്ഞു. എനിക്ക് പറ്റില്ല എന്ന് പറഞ്ഞു. കോളേജിൽ ബുക്കടാണ് സെപ്റ്റംബർ 7 വരെ ബുക്ക് പ്രോഗ്രാം, മൾട്ടിപ്പിൾ പ്രോഗ്രാംസ്. അത് ഓണമായ നിങ്ങൾക്ക് ഒരു മാസം മുമ്പും ശേഷം ലീവ് എടുക്കുമോ? അവരുടെ സ്നേഹം പോലെ. എത്ര മണിക്ക് വിടാം നിങ്ങളെ? 4. Then 3:45 we are finishing the session. Then some friendly talks then go. Okay, 41. Ask me what to teach. Why is it? I can keep anywhere you want. I need a topic to start. Hello. No problem. Artery disease, otherwise called ischemic heart disease. RCHD. CHD, some people use CHD for ischemia. CHD is not congenital heart disease. PDA, netralia, violet blue baby syndrome. Coronary artery disease. Sir, you want? I am going to talk about treatment.
Yes.
All these things come under Kafaja Hridroga. In 20 Nanatmada valleys told by Charaka, there is a word called Damani Pradichayam. Damani Pradichayo, Damani Bhupalevaha. Bhupalevatvam is one of the Lakshanam of Apa. You have the blood vessels. The blood vessels is blocked by plaques, mostly from cholesterol. So it is a Srodha because of Kapha. So Raktam is blocked. Kapha blocks Raktam. This is told in end of Madharakta Chigistan, the Santranti of ischemia. If you read Ashtanadhyam, Madharaktam, N, this concept is told. This is used in DAOs, ischemias, carotid atherosclerosis, everywhere. Coronary artery disease. So in all coronary artery disease, you should ask about the family history. Achanakam Amaikam Hridaya Undo. First question. Second question, stressful life ano. Third question, smoker ano. Fourth question, diabetes undo. ഫിഫ്ത് ക്വസ്റ്റ്യൻ എക്സസൈസ് ചെയ്യുന്ന ശീലമുണ്ടോ? പിന്നെ ഹൈ ഫാറ്റ് ഡയറ്റ് കഴിക്കുവോ? സെഡൻഡറി ലൈഫാണോ? ഫാമിലി ഹിസ്റ്ററി ഉണ്ടോ? ഡയബറ്റീസ്, ഹൈപ്പർ ടെൻഷൻ ഉണ്ടോ? മദ്യം ഒരുപാട് കഴിക്കുവോ? ഇതൊക്കെയാണ് കാരണങ്ങൾ. കൺജനിറ്റൽ ഹാർട്ട് ഡിസീസ്, മൈട്രൽ വാൾ കൊളാപ്സ് ഒക്കെ ഉണ്ടോ? നിദാനം. സിംപ്റ്റമറ്റോളജി, chest pain. Chest pain is a very big topic. The cardiac pain will be a central pain, pressing, stabbing in nature, and it can radiate to the hand, to the jaw, to the back, to the right hand. That pain is called angina, and you have two anginas, stable and unstable. Once you do a very serious activity like climbing a mountain, you get angina, that is stable. You do not know when you are simply sitting and you get chest pain, unstable. Unstable is more dangerous. Stable is predictable. So in acute phase, if you know he has angina, what will we do? Sir, with your permission, I will add some allopathy also. Always you should rule out gastritis. If there is no gastritis, you can give aspirin. The standard dosage of aspirin is 325 milligram. It is called adult aspirin. In acute rheumatic fever, you give 2 aspirins. So, we are going in the train, they get chest pain. Ulcer illa, if we know, you can give 2 aspirins. Now you get dissolved water soluble aspirin, take half glass of water, put aspirin, then you can take. But nitroglycerin you are not supposed to give. Only when you check the BP, then you can give nitroglycerin, glycerin. The BP is 150/100. You can give 5 milligram isosorbitrate tablet sublingual. We have Dhanvantram sublingual also. In many conditions it is useful. This 150/100 you can give. If it is 90/70, you don't give.